Thank you, Professor Manal, for the kind introductions. First of all, I want to thank the organizers of this conference to have given me the opportunity to come and share our experience as Uganda. My name is Kenneth, and I'm the founding executive director for the National Organization for People Living with Hepatitis B, and I also represent the African region at the World Hepatitis Alliance as the board member. So I'm just going to give a brief background of who we are, and then later on I'll go into the gist of the matter to discuss the monitoring and testing experience for our country. Oh, sorry. So the National Organization for People Living with Hepatitis B was started in 2012 by, of course, people who are living with hepatitis B. I'm myself a patient, so when I found myself positive in 2012, I decided that we should form a patient-driven organization, because at that time there was a lot of discrimination and stigma in the community, and even the health workers actually didn't have a lot of information to give to the patients, and that caused a lot of anxiety and the stigma inside. So we are just an NGO, and we also subscribe to a number of organizations like the World Hepatitis Alliance, ALPA, ITAN, Hepatitis B Foundation, and the rest. So these are some of the advocacy activities that we have been engaging through since 2012. And in 2013, we actually wrote officially to the Ministry of Health showing our dissatisfaction on the way the ministry was handling hepatitis B, because there was a lot of anxiety in the community and there was nothing that was being done by government. So we wrote to the ministry, and in 2014 we held a charity walk that actually involved so many high-level stakeholders, the ministers, and the president actually was supposed to be part of this walk, but unfortunately he had a trip, so he had to delegate. But during this charity walk, we saw that a lot of commitments were done through the president's speech, and in that same year, we saw the allocation of $3 million towards hepatitis activities. So this is domestic funding, it is not external funding. So also in the this following year, 2015, the Ministry of Health, through the president, launched the adult mass testing and vaccination in areas that had high prevalence in the country. So we have also been a leader at organizing the regional advocacy meeting, the African Hepatitis Summit, which was held in Kampala, that brought over 600 delegates across Africa and other regions. So in this meeting, we had high-level stakeholders. We had the Minister of Egypt, who actually gave a keynote address and pledged to support and treat 1 million Africans for hepatitis C. So going to the key discussion of this session, that is the surface area for Uganda as a country, and our population is about 41 million people, and our GDP is there. And our doctor-to-patient ratio, you can see how bad it is, but that's what we can afford to do. So according to the latest data that we have, the prevalence of hepatitis B in Uganda is 4.3. And HCV prevalence is actually not clear, but information from the blood bank shows that it is about 1 to 2%. So the government response, there has been actually a lot of progress that has been done. We see a lot of high political level commitment. We have seen the allocation of the $3 million towards hepatitis B activities, and actually the political will is at presidential level. So that is the beauty that we have. There has also been childhood immunization. This is not the birth dose though, so it's still the pentavalent vaccine that is being given. And the allocation of the 3 billion shillings actually goes to the procurement of testing kits and some medicines. So the laboratory testing and diagnostic, we have widespread provision of hepatitis B surface antigen rapid test kits in the designated districts where the Ministry of Health is actually carrying out the mass adult screening and vaccination. And we also have establishment of viral load for hepatitis B, leveraging on the pre-existing efficient sample transportation system, which is used by the HIV program. And also have some bit of increased population awareness on the burden of hepatitis B. And the government has actually screened over 4 million adults and adolescents between the age of 15 to 65 for hepatitis B. And 250 patients have actually been identified who are living with chronic hepatitis B. So, of course, as a measure of precaution, the blood bank has been able to screen all the blood products for hepatitis B and C, and also use the auto-disable needles, which are available at all the health facilities, to avoid the usage of the syringes. So there are a number of plans that have been developed. For example, we have the National Strategy for the Control of Hepatitis B, 2015 to 2019, it is still in draft form. The guidelines for the treatment and prevention of hepatitis B have actually been completed, and they were supposed to have been launched a few weeks ago, but because of some reasons they were not. But the good thing is that they are in place and they have been printed. So reporting tools for hepatitis B have also been developed, though they are not yet disseminated at public facilities. So these are some of the challenges: limited access and stockouts for screening and diagnostic test kits. Of course, these are not always available in public facilities. At sometimes they are not there, and the implication here is most affected persons pay for basic investigations like the LFTs, CBC, and the rest of those other tests that are required by the clinicians. So we also have lack of a clear referral system for hepatitis B patients, especially those that test positive, and this has actually hindered the loss to follow up. Most of the patients actually do not come because there is no clear referral system. So, of course, we have no data collection at facility, district or national level to support the evaluation of the HBV and HCV, and also the complications, then the response to care, then the linkage to care, assessment, treatment, and outcomes of the 250 affected patients is actually also not clear. Then there no formal assessment of the liver-related mortality and morbidity, although some facilities have some data, so there is need to actually go through this data and find out the exact mortality associated to hepatitis B. So there are opportunities, however. Uganda hosted the first African Hepatitis Summit in June, which was a high-level advocacy meeting that brought so many people, and I'm glad that some of the colleagues in this room are also part of this meeting. And in the meeting, like I said, the Ministry of Egypt announced the support of treating over 1 million Africans who are living with hepatitis C. So plans and negotiating documents are in progress, and Uganda has also a strong patient-driven civil society organization. So what is the way forward? Dissemination of the guidelines. I've said the guidelines are already there in place, but they have not yet been disseminated to public health facilities. Introduction of the birth dose, which is actually very key in preventing and eliminating of hepatitis B. Mobilization of both internal and external resources and towards hepatitis B response. Then engagement with communities, strengthening advocacy and community mobilization. Reliable and affordable screening tests for HCV. This is still a very big problem in Uganda. HCV is still done by specialized laboratories, and this hinders a lot of... So there's also need to actually find the exact burden of hepatitis C in the country, because we do not have like a national data on hepatitis C that is generalized to the whole population. So finally, the elimination of viral hepatitis can only be possible if the patient voice is put at the forefront of all the programs for hepatitis C and B elimination. Thank you so much for listening.